This session regardless, and this is conducting multinational drug trials, and Brennan Spiegel is co-chairing this with me, and I'm Nick Talley. Now I'm going to introduce our first speaker, who is Brennan, and he at very late notice, I believe, replaced Richard Hunt, who was going to give a talk along these lines. Richard couldn't make it to the meeting, very unfortunately, but Brennan very kindly stepped in. And he is an associate professor at UCLA, director of the Outcomes Research Group. He was the co-chair of the Rome Outcomes Committee, and he just ran the LA Marathon in 3 hours, 53 minutes with Vibram 5-finger shoes. They're the ones with no cushions. He's an amazing guy. Brennan, give us a talk, and you're going to talk about unique problems in multinational studies, ethical issues, inclusion criteria, and recruitment problems. And could we have the first slide up, please? Thank you.
Thank you. That's the first time I've been introduced from the feet up, I guess. All right. Well, good morning, everybody. I'll maybe vamp for a moment or two while the slides are upcoming. Oh, there you go. Okay, well, thanks so much to Rome, to Doug, and to all the organizers for inviting me to be here today. This is really a unique conference, and I think a very important and timely set of topics that we're going to cover this morning and throughout this entire conference. And for me, this was a little bit out of my usual comfort zone to give this talk. Because this isn't something that I spent a lot of time thinking about. But as I was really preparing for this, I started to realize I should spend a lot more time thinking about some of these issues, some of the topics that we'll be talking about this morning. And just in preparation for this, it was really an eye-opening experience to think more about some of the very practical issues that we need to think about when putting studies together. So this is what I'm going to talk about. I'm going to start with the end when it comes to clinical trials, and by the end I mean the outcomes. When we do clinical trials, we have to measure whether people feel better or not, whether they do better or not, and we do that in many different ways. We do that oftentimes with patient-reported outcomes, or PROs. So I want to start with that, starting more in my comfort zone, then I'll work out from there. And you'll hear from the other presentations to follow more perspectives internationally on patient-reported outcomes and some of the issues that we face internationally and how best to craft these patient-reported outcomes. So consider this item from a questionnaire. This is an existing item from an existing published questionnaire. Over the last 4 weeks, how often did you lose wind from your anus when you did not mean to? Okay, so this is out there. This is an actual item. Don't know if anybody in the room wrote it or has used it. The reference is below. I just came from a meeting at NIH with Donald Patrick, who's in the back. Both of us are part of this PROMISE network. I'll talk more about this PROMISE network on Sunday. But we could spend in that room 2 hours talking about this particular item and all the psychometrics that go into developing items. And more we're starting to think about translatability of items and whether the terms here in this phrase would translate appropriately even within English from one country to the next, right? The term wind is not used in this country very often. So this alone, it would be maybe a difficult item. Do you have excessive flatus? So think about that one for a second. This is a binary questionnaire, or item, yes, no, suggesting that I guess it's a binary thing, flatus, or whether it is excessive. What does excessive mean? Does everyone even know what that word means? I'm going to guess in this room people know what excessive means. But as we start to leave this room and go outside and go from one socioeconomic strata to a next and go from one country to a next, the term excessive may not be understood or may be understood quite differently from one place to the next. In the past 3 months, have you experienced a feeling that your bowel motion is incomplete more than a quarter of the time? Okay, so what's wrong with this? You can start to think to yourself what may be the problem or problems. But what I want to point out here is the issue of numeracy. We talk about literacy and how literacy varies. We don't as often talk about numeracy. And we often take for granted that all patients in a clinical trial have basic fundamental numeracy skills. What does 1/4 of the time mean? That's hard enough for numerate people to determine, but for innumerate people, understanding what 1/4 of a time is almost impossible. There's been really interesting experiments even with undergraduates, asking them what is a probability, and can they estimate probabilities. They've done experiments where they put marbles in a bag, 95 blue marbles and 5 white marbles, and they ask them what is the probability of getting a white marble. And about 50% of undergrads are unable to answer that, which is incredibly amazing to me. So numeracy is an issue. How concerned are you about your illness affecting your health insurance? Well, this one is kind of obvious because depending on what part of the world you live in, health insurance will vary. For some people, this is a nonsensical question because everyone in their country has health insurance. Ami Sperber, who helped me a bit in preparing for this talk, pointed out that there was a similar question proposed for a study he was conducting in Israel, and he pointed out that question really wouldn't be relevant where he's from. So these are some of the issues to think about, and I want to talk about some of these areas. And the obvious point here is that patients are not monolithic. This is, again, obvious, but it's easy to forget as we prepare protocols for clinical research and clinical trials. And I'm talking more broadly in my discussion, not just about randomized controlled registration trials, but any form of clinical research that we conduct. We have to think about all of these different factors that vary from patient to patient across socioeconomic strata and across countries. So I've mentioned language, not just the native language, but even within language, variations in the meaning of words. I mentioned the example of wind, which isn't a term that we use here. Feeling blue versus feeling down, feeling depressed, another example. Blue is not widely understood by everybody. That's another example that has come up in the SF-36 in the past. Literacy, I've mentioned as well. Excessive, what does that term mean? What does the word distension mean? I'm going to come back to distension in a little bit because there's some surprising information there from my perspective. Anus. How should we expect all of our patients to know what that is necessarily, right? So it's almost a facetious question for me to pose it in this room. But what is the anus? What is the rectum? What is this stuff? So we need to really understand how well our patients can comprehend the questions that we're asking them in these clinical research studies. I've discussed numeracy briefly already. Culture. Right? In some places, it's just completely unacceptable to ask about my anus. That's just not a question that I'm willing to answer. Or that's not a question I'm going to allow my wife to answer, as you'll see in a few slides later. And of course, variations by country. And the most obvious that I've given so far is just presence or absence of health insurance, which wouldn't be necessarily an outcome measure in a clinical study, but certainly would be a descriptor as we're going through patient populations. So let me talk a bit more about developing patient-reported outcomes for diverse patients. And we'll hear more about this in the next talk with more specific examples of how information can be interpreted, for example, in Japan versus in the United States, how words are understood and what their meaning is. For most functional GI disorders, we rely on patient-reported outcomes to estimate the effectiveness and efficacy, depending on what kind of study you're doing, on the clinical interventions that we're deploying. And they really need to be developed in a way that accounts for all the different variables that I've been mentioning so far. But when we look at this, we find out that most PROs really do not follow best practices. And as I mentioned earlier, I'm part of this PROMISE network, and as part of that process, we've gone through every patient-reported outcome measure ever written and published within all of gastroenterology. It was a pretty overwhelming activity. And we've just written up this manuscript. And one of the things that we did was perform quality scoring on these PROs to see the degree to which they were validated and the degree to which they're psychometrically valid and reliable. And one of the things we looked at, which is very important to these promise measures that I've been kind of mentioning, is readability. The items and the questionnaires need to undergo readability testing. And when we look at the existing GI questionnaires, fewer than 10% of them have any kind of specific information about how readable the questionnaires actually are. So that's kind of surprising, since it's patients who need to read them. And only 1% of them provided any data stratified by demographic information in terms of the performance of this questionnaire across different socioeconomic strata, across different genders, across different income levels, or race, or different populations. So this, too, is important. It's an extra step to take to demonstrate that a questionnaire is readable, understandable, comprehensible, and psychometrically valid in different populations. But virtually no questionnaires in our field have gone to the extent, including questionnaires that I've developed, to do this sort of thing. So it just points out that all of us have been sort of, I wouldn't say turning a blind eye, but not emphasizing these factors as we go about developing outcome measures for clinical research. And that's why I wanted to start with the end, because that's how we determine if something works or not, by measuring these patient-reported outcome measures. So we need to do a better job, and I'll start with myself, in developing these PROs so that they make sense for very broad and diverse populations. Now, there are some best practices that have been developed to ensure cultural and demographic validities of these patient-reported outcomes. And the first and obvious step is to ensure appropriate breadth of patients when we perform content validation. So right now, there are many efforts underway to develop endpoints for irritable bowel syndrome in particular, perhaps most important of which is the effort under the CPATH initiative, which I think you'll hear a bit more about as this meeting and the next meeting go on. But in that effort and other efforts, like the work we're doing under the NIH grant for PROMISE, it's incredibly important that we are specific about the cells that we need to fill when putting focus groups together. I'll show you a form that we have to fill out every month for the NIH in terms of the cell numbers across different socioeconomic strata, different races, even different cultures, to demonstrate that we're able to have a broad enough population from which to draw and vocabulary, to cultivate vocabulary, and to make sure we're capturing different illness experiences, and then ensure that that information is faithfully transmitted to the PRO that we're developing. There also need to be debriefing interviews for all of the items in a patient-reported outcome. So this is different from a focus group. In a focus group, we get a bunch of patients together and we talk about their illness using a structured approach. This can also be done in one-on-one interviews. But after all of these items are developed, we need to go back to a diverse group of patients one-on-one and show them the item and ask them questions about it. Like, do you understand what this item is trying to ask of you? Can you restate this item in your own words? Are there any words in this item that you don't understand or are unclear to you? What do you think about the response choices in this item? Are those the right response choices? Do they capture are they the response choices you would have asked if you had to put this item together? And you have to do that for at least 5 patients per item. And if there's any problems with the item, you need to revise it and go back to another 5 patients and have them on. So finally, through this iterative process, the items have been sort of signed off by a diverse group of people who experience the illness. And that's just in one language. So it's very time-consuming, and very, very few PROs in gastroenterology have undergone this level of validation. The other important piece of this is to actually work with a health literacy expert. We're fortunate in the PROMISE Network to have access to people who really understand this stuff, to linguists who know about translatability of items and can help determine up front if an item is going to work from one culture to the next or from one country to another. So this is even considered as we write the items in English to make sure that these English items will be reasonable in other languages as well, to the degree that that can be determined. There are literacy calculators like the SMOG. I don't know if anyone's heard of the SMOG. Anyone used the SMOG before? Okay. You know what it stands for? I won't put you on the spot, but it's kind of a... So it's the simple measure of gobbledygook. That's what the SMOG is. Yeah. So that's what it is. In reality, it's a simple measure of gobbledygook. So the SMOG calculator is a real thing, and there's this very complex algorithm that underlies it. And there's a free calculator. You can go online and put text into the calculator, and it will analyze it for you and give you the projected grade level that the text is written in. So it's a really great mechanism to establish the literacy of your questionnaires or whatever you're trying to develop. So there is a website. I should probably have put it down there. I don't think I did, but it's easy to find if you just type it into Google or something. And I mentioned earlier that it's important to have subgroups and to have psychometrics for endpoints developed in different subgroups, and then to conduct forward and backward translations when adopting in different languages. So these are kind of the best practices that are out there as it pertains to the endpoints themselves. All right. So here's a term. The term is bloating. This is a important symptom that most of our patients, not all, but most of my patients have in one form or another, especially functional GI patients. And it's a term that we kind of have, we think, a shared understanding about. But when we ask patients, what does bloating mean to you, this is just the beginning of the different terms that people employ. And these are some of the terms that patients with IBS have. We published this last year. And you can see that people are referring to lots of different things when they think about their bloating. Sometimes they're talking about the way the bloating looks. It's physically distended or swollen or puffy. Other times people talk about the way bloating feels. It's a fullness or a heaviness or an uncomfortableness or feeling gassy. Others refer to sort of a functional component, like I feel like I need to pass gas. What I mean by functional, sort of mechanical, I guess. But the point is that people have different understanding. Even in a group of patients who have the same condition, IBS, who all speak the same language and are more or less from the same place, they have different understandings for what the term bloating means, and points out that the same word can mean very different things to different people, even within the same language. So this gets really complicated as we start to move out to other languages. What is the word for bloating in Hebrew, and how does that compare to the English translation? Does the word hinchazón, which is the Spanish word, really mean bloating? And where's Max? Because we've talked about this before, right? And maybe during the Q&A, I think we have more time than we originally expected because Richard's not here. We can hear more about some of your take on whether that's the right word. What word do we use in Spanish? So we all have our own languages that we can think about. What is the right word for this concept of bloating? And this is a challenge when we're dealing with functional GI disorders where the patient report is the gold standard currently for how we determine success or failure of our therapies. How about the word distended? Okay. Now this is a word that I'm guessing everybody in this room is familiar with or knows in one form or another. We asked patients about this term, and here are some of the results that we got. We had an engineer. He was a mechanical engineer, said, and he was a little embarrassed to admit this, but he said, I really don't know what that word means. We showed him an item with the word distended in it. He said, what does that mean, distended? He just didn't know what it meant. And at first I thought, God, that's so surprising. How can he not know that? He's an engineer, right? I mean, don't things get distended when you're, I don't know. And another patient said, I don't know, that sounds very clinical. I'm not sure what it really means. It sounds really clinical. It sounds like something a doctor would say. And you start to realize we live in a different kind of universe in our world, and I'll show you a quote in a slide or two that puts this into perspective in a really striking way. But the terms that we use, we know this, are not the terms that patients use, but sometimes we lose track of that, even those of us that are and those of you that are attuned to this whole concept of communicating with the patients. We still use words that patients don't really understand. So we've started moving away from the word distended because it's very technical to patients and not everyone understands it. So we shouldn't be using words that people don't understand. A little bit more on literacy. This is, I'm no expert on literacy, but the data are striking. And just in the United States alone, there's over 100 million Americans that are functionally illiterate or have marginal illiteracy. Let me just show you some data here. This is from the 2003 National Assessment of Literacy. And it shows you, in the United States anyway, the breakdown of different groups in terms of just general literacy as opposed to health literacy, which is different. Proficient, intermediate, basic, and below basic, and you can see the distribution for all adults in the United States and the millions of adults that this tracks with. So the point is that we have many patients, people and patients in studies who are either entirely illiterate at times or have basic or intermediate but not really levels of proficiency for language, understanding language. And it's important to distinguish general literacy from health literacy, which is really a higher level of integration because it requires not just that patients understand the words, be able to either read words or understand the spoken word, but there's a second order of integration in order to act upon the doctor's advice, let's say, to understand why they need to take these pills, and then to remember to take the pills, but that's more of a cognitive issue. So the point is that health literacy is a much higher level of literacy than just simply reading text. And it's broadly defined as the constellation of skills required to function in the healthcare environment, which is one of the sort of textbook, sort of throwaway definitions, but it points out that we're talking about more than just being able to read words when dealing with health literacy. So this is an example of trying to work around literacy or illiteracy. This is from Dave Sella's group. Dave Sella is in the PROMISE consortium and has done work for years and years around literacy and a lot of other issues around how best to administer questionnaires. And here they have a screen that patients can just touch the ear button, and then they can hear what the question is and hear what the individual response choices are. Here's an example of a study where a questionnaire was evaluated, and they compared patients with high literacy versus low literacy to see what their mean scores were on the same items. And this is the line of identity, where you would hope that there wouldn't be a whole lot of variation from the identity line between these two different groups. And for each of these individual items in this fatigue questionnaire, there wasn't a significant deviation from the line of identity. But then they looked at some of these other items that are in this fatigue questionnaire and found that some of these items started to deviate substantially, statistically, from this identity line, and were therefore highly dependent upon the underlying literacy of the patient. Even if the patient was able to read the questionnaire or had it read to them, their choices, their responses were systematically different depending upon their level of literacy. So, again, it points out that this kind of work needs to be done more frequently and isn't done that often. And when we do check it, we start to find things that are inconvenient truths, that some of the questionnaires that we employ in clinical research have not been developed for people with low levels of literacy. And in essence, we're systematically excluding these populations by not developing questionnaires that have been tested by them. So a little bit more on this general concept of representative sampling. We need adequate representative sampling for study enrollment as well, not just for the endpoints that we are creating. And this is obvious. There are many challenges to this. People who tend to enroll in clinical research, or people that enroll in clinical research, tend to be more literate in the usual sense, and health literate in the more specific sense than those who do not enroll in clinical trials. And this is something that we know. In the United States, non-English speakers are often excluded, either explicitly or implicitly, from the studies. If the investigators themselves don't speak other languages, they may feel less comfortable recruiting people who speak other languages, even if the protocol doesn't specifically exclude individuals who speak in other languages. And even within language, we may have trouble recruiting underrepresented groups with sufficient numbers. Let's see here. Yeah. So here are some other specific challenges to recruiting less educated patients, which is, again, a challenge that cuts across all cultures, all countries. Less educated patients tend to be less aware of the opportunities for research. They may not read the newspaper and see advertisements. They may not be listening to the same radio stations that have advertisements on them. They may not be reading the same journals or magazines that provide advertising for research. So we talk about, through advertising, we get people from the community as if this is some generalized sample, but this is a sample of people that read advertising. Right? What about people that don't read advertising? How do we get those individuals into clinical trials? And even if they do read advertising, and there's quite a bit of data on this, some patients feel stigmatized or they feel ashamed. They may be embarrassed by participation because they're afraid that even if they do enroll, they're not going to fully understand the directions or understand the purpose of the study, and they feel embarrassed about that. And we don't always really explicitly address that or develop our instructions to deal with that. They certainly may be unfamiliar with some of the more modern techniques that we're employing to collect information within the context of clinical trials, and some of them are listed there. So what are solutions? There are no easy solutions to this, but one is to try to bring study opportunities directly to those groups, and that's resource-intensive, time-consuming. We're struggling with this right now with our PRO work for this Promise network. We're having more and more difficulty finding people who have only a high school education and nothing more. So we're trying to determine how to reach those people. Maybe we need to go into the public clinics and set up IRBs there and actually be in the GI clinics there and recruit people actively from the waiting room. That's a time-intensive, time-consuming thing to do. But the point is to bring the opportunities to patients in ways that are maybe a little less commonly employed. To script the recruitment materials so that they're, first of all, readable and understandable, but also that they're sensitive to the fact that people may feel embarrassed and ashamed, and that could be addressed directly in instructions themselves. Literally, there's no reason to be embarrassed or ashamed. There's no right or wrong answers to these questions. Literally address that straight up, and to provide alternatives, obviously, to the e-devices that many patients may feel very uncomfortable using. And that's not just a literacy thing. That's certainly an age thing as well. As we all know, older patients may be less willing to use these devices than younger patients. So I don't know if any of you ever read this book, The Bell Curve. This was a very controversial book that came out in the mid-'90s, and it had to do with intelligence and how intelligence drives the formation of class structures. And it's a very interesting book, but there's a quote in it about 50 pages in that basically says if you've gotten this far into the book, then you're very different than almost everybody else in the world. And then it goes on to say, think of your 12 closest friends or colleagues. Does it surprise you that the odds of having even half of them be college graduates, at least in the United States, is 6 in 1,000? Many of you will not think it odd that half or more of the dozen may have advanced degrees. But the odds against finding such a result among a randomly chosen group of 12 Americans is 1 million to 1. So that's pretty striking. It really points out that, we're in rarefied air, and we're the people who are always talking about the patients and the people and subjects, and our studies show, and these are the implications for people in general. We are not people in general. That's not a judgment. It's not a good or bad thing. It's just that we are at a very different we're in a different group. And it's sometimes hard for us to realize that we need to think beyond our own upbringing, our own background, our own sort of environments and cultures. And this is cutting across wherever you come from. The fact that you're in this room means that you're probably closer to that 1 in a million than to others. So we have to keep this in mind as we're putting PROs together and putting trial protocols together and so forth. So I'll finish with a few last examples of cultural barriers. This is a slide that Ami provided for me, and during the Q&A he might provide more insight about this. But he pointed out that in an epidemiologic study in Israel, looking at patients with IBS, references are down there, he had difficulty recruiting these two groups. In particular, Arab men didn't allow their wives to participate in this study, and Bedouins lack telephones and live in scattered regions. They're semi-nomadic. It's hard enough for me to go to the public, at least I know the public clinic, I can find some patients. If I can't find them and they're out roaming the desert, I don't know how I'm going to get those folks into my study. So those are some very particular challenges to putting studies together. Here's a study. I think we have an author in the room, right? That looked at variations in bowel patterns in Hispanics versus non-Hispanic whites. And it's amazing that if you look at the literature, you don't find very many studies like this that actually look at GI symptom patterns stratified not only by males and females, where there's more and more work, but by, in this case, Hispanic and non-Hispanic. So the results themselves aren't as important as the fact that this study was even done. And that's a remarkable thing. We need to spend more time thinking about these kinds of cultural, ethnic, and racial variations. Now, if you do any work with the NIH, which many of you do, more and more we're under the gun to provide very specific information about the demographic characteristics of our patients. There's a whole page about this, and recruitment and retention for diversity. This is NIH Form PHS 3982590. If it doesn't have 4 integers in it, it can't be an NIH form. And these are the cells that we need to fill out every month as we continue in our research recruitment. Latino, non-Latino, or Hispanic, non-Hispanic. There are differences between those two things. And individual racial categories stratified by men and women. And right now, in our particular study, we have a problem with some of these cells, and that's not acceptable. So just yesterday, I had a nice conversation with my scientific officer to figure out how we're going to get the cell numbers up in one of those cells. So if these things are audited and monitored, and then there's an action plan, it may seem onerous, and indeed it is, but at the same time, if we're trying to achieve adequate representation, we need to have plans to do that. So this is my last slide, some areas for research in this. To begin with, PROs, I've pointed out, we can all do a better job in making sure the outcome measures that we're creating for both registration trials and clinical research in general can be better validated cross-culturally across all the different factors that I've discussed: literacy, numeracy, culture, gender, etc. We need better understanding of cross-cultural variations in knowledge, attitudes, and beliefs as it pertains to functional GI disorders. And we should also do more research looking at biomarkers and physiology cross-culturally. For example, in hepatitis C, we've now learned that there are very important differences in response to interferon ribavirin, depending upon whether the patient is black or not. So we need to do that work as well in functional GI disorders. And some of this I'm stealing from a great review that Ami wrote on this topic. And in this review, he goes through different types of areas of inquiry, and I've listed them there. So I'm going to end with that. Thanks for your attention. I look forward to the next.